Hey guys, and welcome back to Lil U Life. I'm Dr. Gibson Gray, and we're going to cover a subject you won't want to miss today. We'll talk all about apnea, an issue that affects almost all premature babies at some point during their NICU journey. So let's get started. Apnea is defined as not breathing for 20 seconds or more. Any baby can have apnea, but is more common in premature babies. Typically, when infants have apnea, it's followed by a drop in their heart rate, we call that bradycardia, and then a drop in their oxygen levels. We call that a desaturation, or DSAT for short. Sometimes the monitors may or may not pick up this apnea, but they may recognize the brady or the DSAT. So this makes interpreting these events a little bit tricky at times. Apnea can be divided into one of two types, central or obstructive. So let's start with central apnea. Central apnea happens when the part of the brain that tells us to breathe either isn't mature yet or is dysfunctional for some reason. So in preemies, this is easy. It's just immature, and this naturally gets better with time and maturity. Sometimes other things can make central apneas worse, like inflammation from infection or even routine immunizations. When we have babies that have a sudden increase in the amount of apneas, the first thing we want to do is rule out infection. Central apnea can also be caused by something directly affecting the brain itself, like bleeding or infections, such as meningitis. This is why we may see more apneas when a baby has IVH or brain bleeding. Check out our other video about IVH for more about this. There are also a few genetic conditions that may be the cause of central apneas, such as trisomy 13 or trisomy 18, but these are not terribly common. Central apneas that happen in term babies cannot necessarily be blamed on immaturity, so we have to consider what else could be causing them. By far the most likely reason would be infection. But if infection is ruled out, then seizures would be the next most likely thing on the list. Now let's move on to the other category of apnea, obstructive apnea. So while central apnea is all about the brain's job of telling the body to breathe, obstructive apnea happens when there's some type of blockage that keeps air from entering the lungs. In these cases, there's nothing wrong with the brain's ability to control breathing. So in cases of obstructive apnea, something is blocking the airway during the process of breathing. This may be a congenital abnormality, meaning they're born with it, like a small jaw, or an airway mass. In these cases, surgery is usually needed to fix the cause of the apnea. And sometimes there's genetic conditions that may lead to obstructive apneas, like Beckwith-Wiedemann syndrome is an example. This is a condition in which the tongue is very large, which leads to blockage of the airway. The most common cause of obstructive apnea in preemies is actually GE reflux, or gastroesophageal reflux, and spitting. This happens when a baby spits up, begins to choke, and then closes their airway to protect it. This is actually a normal response to reflux and is a sign of a healthy and mature developing neurologic system. So, once we've decided which kind of apnea is happening, what do we do about it? For many types of obstructive apneas, the treatment involves fixing the anatomy problem. Unfortunately, we cannot fix any of the genetic causes. So with central apneas, we also want to treat any underlying causes like infections or seizures, but for central apnea of prematurity, we have another tool in the toolbox: caffeine. Yeah, that's right. After telling moms to avoid caffeine the whole pregnancy, what's the first thing we give to your preemie? Caffeine. Well, caffeine actually works by stimulating the part of the brain that controls breathing. But it can take the equivalent of 10 to 15 cups of coffee per day to achieve this. That's a lot of caffeine. But it has many benefits to premature babies. So I love caffeine for myself and for my babies. So caffeine is not a medicine that babies will need to take forever, just until they outgrow their apnea of prematurity. But caffeine does stay in the body for a long time, so a common practice is to monitor babies for some period of time after stopping the caffeine to ensure they don't have any more of those apneas once the caffeine is out of their system. The length of time varies that they watch, but the idea is the same, to make sure that all of that is out of their system before they go home. Sometimes a baby actually may need to go home with an apnea monitor if they haven't totally outgrown their events, but otherwise are ready to go home. They're eating well, they're breathing well, they're growing well, all of the things. So apnea monitors are typically worn all the time except when bathing, and they're monitored by a home health company which communicates with the baby's pediatrician periodically. This is a key difference from the ones that you would get in the hospital versus the ones that are over the counter, but we'll get to that. Once the baby is not having any more events, they may not need to continue to wear the monitor at home, but that decision is left to the pediatrician outpatient. So you may hear about baby monitors like the Owlette or Babytone or some of the other ones, but these are commercial products that are not approved by the FDA for apneas and are not monitored by a home health professional. That's the key difference right there. So here with us, we follow the AAP recommendations and we don't endorse the routine use of these items as they have not really been shown to reduce the incidence of SIDS as previously suggested. Apnea monitors should only be used for specific conditions where there's an increased risk of recurrent episodes of apnea, bradycardia, and hypoxemia after discharge. Well guys, you can breathe easy now. That wraps up our talk about apneas for today. I hope this video has been helpful to grow your understanding of a very common issue for many premature babies in the NICU. As always, if you have questions about your baby's care, talk to your neonatologist or other healthcare provider. And don't forget to check us out online at Little U Life to like and share this video for others to see. Comment below and tell us about the little you in your life. Thanks for watching. We'll see you next time.